Hello, everyone. Good evening, good morning, good afternoon. I don't know where everyone is based. I can see a lot of countries, which is amazing. We've reached the 100 magic number quite quickly. Me and Julian were talking on the background about that. Thank you for every single one of you that is here today to learn a little bit with one of the greatest, which is William Faulkner. So before we move on, we don't give certificates for these webinars, okay? So these webinars are free webinars. The only one that we normally issue a certificate is the MRIsafety Forum, which happens at the end of the year, normally in November, okay? So for those of you here now, just be aware that we're not issuing certificates for this session, okay? This is just a free session for you to learn something new or something that you already know, just to refresh. And one thing that I ask everyone is to keep your cameras and mics off throughout the whole session. There's a box in the bottom where you can put your questions on the chat box. Me and Julian will use those questions to do a Q&A with Bill at the end of his presentation. Okay, so the presentation should take around 45 minutes, something like that. And right after that, we will ask the questions live. So if you have any questions, just put them down on the box. Okay, that's pretty much it from me now. I'll later on have some news for you. We're gonna give a code, a free code for discounts on our courses as well. So if you want to use it, I'm gonna drop it down on the menu, and we're gonna also announce another webinar for next month. So before I bring the guest to the stage, I'll pass it to Julian, of course. Julian, please have some words for our guests there. We have more than 100, but at the moment, 100 is our cap. So how are you doing today?
Hello everyone. I want to thank you so much everyone to coming here today. We did it slightly earlier compared to the other webinars, and I was a little bit concerned. I was like, yeah, maybe people would not be able to join. But matter of fact, we already reached our cap for this webinars, which tells quite a lot about the statement, about the support you have been giving us quite a lot, I would say, across this month. And if you've been following the Everything MRI page, you might have probably noticed that we have quite a interesting thing, which is an MRI documentary that just came out. We actually managed to get through the insights, the headquarter of Siemens Healthineers in Germany, and record this unique piece of master in a way within those factory, within where the magic happens. So the first episode is already out. So we talk about the present of MRI, is on our YouTube channel. But if you're interested about the past, how everything was manufactured from the very beginning, stay there, connect to our page because there will be some very interesting news to come. That's the only thing I want to say. But I would say let's go straight to the point, to the topic of the day. Sam?
Yes, so basically today we have Bill Faulkner. Pretty much everyone knows who he is. Hi, Bill. He's going to be talking today about thermal injuries on MR, which is a topic that everyone is very interested to learn about. So, Bill, thank you so much, first of all, to take the time to be here with us today and to present for a cohort of people that come from around the world from where we can see. So, the stage is yours. You can share your screen whenever you're ready. And guys, please drop all your questions on the meeting chat box, and we'll answer them more or less at the end. Okay. So thank you so much once again, and keep your mics and cameras off, as I said before, so Bill can present without any interruptions. Thank you so much.
Oh, thank you so much, Sam. And is everything showing up like it's supposed to? You should be able to see my slide and
Yeah, it's all good, Bill. All
all
good.
good. Okay,
Yeah.
good. Thank you. I'm sorry I had was telling Sam earlier I stopped by Best Buy on my way from lunch today to get a new webcam because what I had was giving me problems. So just make sure everything's working okay. So thank you so much for taking time out of your day to sit with us. And we're going to talk about how to prevent burns, thermal injuries or burns in MR. So, in MRI, we use three very distinctly different magnetic fields. The static magnetic field, time varying gradient magnetic fields, and the time varying radio frequency fields. And they each have their own unique safety, if you will, considerations. In, as far as burns are concerned, we really are only looking at the radio frequency field. I did, last year, toward the end of the year, I did a talk on burns, and some of the questions that people were asking after me, after I did the talk were, well, what kind of field strength was that? Well, what was this? It's the reality is burns can occur across a wide range of environments. And primarily, we're looking at 1.5, 3 Tesla, 1 Tesla, possibly. And I know some of you may be working in facilities or instances where you have very ultra low field. Sometimes these radio frequency burns are not, most often they're generally not an issue at ultra low fields like, 0.2 Tesla, 0.3 Tesla, that sort of thing. So primarily I'm going to be focusing on 1 Tesla, 1.5 Tesla, 3 Tesla systems. Now, when we talk about exposure to a time varying radio frequency field, this is electromagnetic radiation in the radio frequency range. And with the human body, there are biologic effects that occur when you expose a patient to these particular electromagnetic energies. Number one is patient warming. The patient is going to get hot. We are going to introduce heating into the tissues. This is normal. And patients are going to get warm. Thermal injuries, RF burns, are a totally different animal. They're not the same thing. Okay? And it's very important to understand this. Tissue warming, the energy when you expose a patient to MRI, this energy absorbed, the mass normalized rate at which the RF power is coupled to biologic tissue is called specific absorption rate, or SAR. It is in units of watts per kilogram, and that's relative to body weight. Okay. Again, this is totally different than a burn or thermal injury. This has to do with RF power applied to human tissue. And we have limits that we have to go by. We have 2 clinical operating modes. This is defined by the International Electrotechnical Commission, the IEC. The normal operating mode will limit us to 2 watts per kilogram whole body average. First level controlled will limit us to 4 watts per kilogram whole body average. And I really should, you should probably know this. Some of you online have been around. I was looking through some of the names online, and I saw you have been around for a while. And when I started in MRI in 1985, the limit for whole body SAR was, and make sure you understand I'm not stuttering here, 0.4 watts per kilogram was the limit. And in fact, in those days, we did not go above that limit. We had no problem scanning at that. Why, you may ask? Well, we didn't do fast turbo spin echo back then. In fact, we didn't start burning people until fast spin echo, turbo spin echo, was actually introduced. Okay. Be that as it may, current limits are normal operating mode 2 watts per kilogram. First level control is 4 watts per kilogram. For the head, it's 3.2. Now, since we're introducing this RF power into the body, and actually I want to kind of give you a, in fact, let me back up to a slide here just for a moment, because I want to give you some bit of context here. So let's take 4 watts per kilogram. All right, I weigh, oh, give me a break, 100 kilograms, okay? So at 100 kilograms, if you were to expose me to 4 watts per kilogram for 5 minutes, think about that. So I weigh 100 kilograms, okay, and you expose me to 4 watts per kilogram. 4 times 100 is 400. And if you did that for 5 minutes, that's like me laying under a 400 watt heat lamp for 5 minutes, which a lot of people would find comfortable. I, on the other hand, would not, okay? So when you expose, if you were to take a brisk walk around your neighborhood, you get warm. You get warm because of this energy. And it really is kind of like in watts per kilogram, same thing. So you dissipate that energy primarily through perspiration, the blood flow, that sort of thing. But also you have environmental effects, the bore temperature, the ambient temperature of the room, the relative humidity, airflow rate. That's why you have a bore fan that moves air through the magnet. And so this is really important because you're going to heat the patient during the scan. I know we're talking about thermal injuries and burns, but I'm sorry, I cannot get through this without telling you, please do not wrap your patients in heated blankets because they cannot cool. They can't effectively cool and lose energy if in fact you have them wrapped up like a burrito. Okay, so you've got to give the patient the ability to cool, to dissipate that energy. Okay, give them a sheet, and you can take the sheet off of them if they're getting warm. Okay, or take it off their feet. You stick your feet out from under the covers. Cool. Dr. Frank Shellock, in one of his textbooks, has a statement that says various health conditions may impair an individual's ability to manage a thermal challenge, and that includes fever, obesity, old age. I'm right there with them. Also, you can have medications such as diuretics, beta blockers, calcium blockers, amphetamines. Sedatives. These can alter a patient's thermoregulatory response, which means that these can result in a patient not being able to cool effectively, okay? So understand that your patients, particularly if they are sick, are challenged with dissipating this energy that you're putting in them. Therefore, I would, if at all possible, I would like to maintain normal operating mode as much as possible. If I have to go to first level, fine, I understand it. We got to get the diagnosis. But if I have the opportunity to and the capability to go back to normal operating mode, I should do that. I should try to stay around whole body, 2 to 3 watts per kilogram as much as possible. It's not a safety issue. You're not going to melt the patient. It's a comfort issue, okay? We're not talking about burns. We're talking about patient warming and patient comfort. So try to stay in the normal operating mode as close to 2 watts per kilogram or so as possible, and it's going to make the patient more comfortable. Now, there's also this thing called SED, which is now called SA. They changed the name of it, but it's the total absorbed energy. It's kind of like the cumulative SAR, specific absorption, and some systems may actually have a hard limit of 14,440 joules per kilogram. And depending on the age of your system, it may shut off if you reach this. I will tell you that my understanding is the IEC has now backed off of this in terms of requiring a hard stop, so that again allows you to possibly go above this limit. The patient's going to be extremely uncomfortable. I can tell you that, okay? Because again, laying under a heat lamp, it's more of a patient comfort issue. In fact, the ACR says that the thermal load associated with an MR examination is a separate phenomenon from focal RF-related thermal injuries, that is, burns. Although a patient may experience discomfort, an actual burn's not going to occur if this load is sufficiently dissipated over time or space. And I'll show you what we mean by that in a minute. And the ACR further states that limiting the specific energy dose, the total cumulative SAR, does not necessarily reduce the risk of a thermal injury, okay? So these are two different things. So SAR and the total dose that you're giving the patient, especially in the absence of any kind of an implant or device, does not mean that you're going to eliminate the risk of a burn. And this is what's extremely important to understand. They're two different things. There's patient heating, and then there's a burn. And of all the things I've ever seen, this is probably one of the best kind of illustrations, if you will. So if you lay out in the sun, you get this diffuse distribution, if you will, of the energy, and you're going to get warm, okay? If you're just laying out in the sun, okay? This is what the ACR means by distributed over time and space. But now, if you take a lens or a magnifying glass, and I know you may have done this as a kid, I know I certainly did, and you take the same energy from the sun and you focus that energy into a location, then you're going to get a burn, and you're going to get a burn very quickly. Now keep in mind, it's the same energy, it's just focused. Think about focused ultrasound. Some of y'all that may be familiar with that from a therapy standpoint. Ultrasound's, not harmful to tissue, but if you focus it, right, you focus that energy, then you can create a thermal effect. And with MRI, you can create a burn. Now, there are three primary ways that you can get a burn in MRI. And there's variations to each of these, but I'm going to take these three top categories. Number one, what's called a proximity burn, which is due to bore wall contact. Listen carefully to what I'm about to tell you. I'm going to tell you a couple of times. You have a cylindrical bore magnet, 1.5 or 3T. I mean, the other ones we'll have to take, differently, but 1.5 or 3T. Do not allow the patient to touch the bore wall. I don't care who told you what. They are wrong. Do not allow the patient to touch the bore wall, okay? Sheets and pillowcases don't count. We're going to talk about this. But this is a really big issue because this is as far as I can tell, this is the number one source of a patient burn or injury is contact with the bore wall, okay? Second, another one is pinch points, that's skin-to-skin contact, very common as well. And then resonant circuitry effects, which has to do with metallic items. So we'll talk about that. So when you are using the majority of coils that you use, and again, I'm going to want to reiterate, I'm talking about 153T cylindrical bore magnets. Other magnets are going to have to be a one-off thing, and I don't want to get into it on this one, but cylindrical bore magnets, 153T, which I'm sure most of you have, the majority of the time you are transmitting with the integrated RF body coil, okay? This is a coil within the magnet enclosure. It's right behind the bore wall. All systems are designed like this, okay? This is the coil that is used primarily 98% of the time for RF transmission, okay? The RF field is three-dimensional. This is courtesy of Dr. Manny Canal and his Magnet Vision application. If you were to look at the RF power distribution along the central axis of the patient, the greatest amount of RF power is going to be at isocenter. But as you move away from isocenter, it's going to drop off. This is true only in midline. If you look at this scale here with color, notice that the highest RF power is white, and notice where that is. That is up against the bore wall, okay? So all areas that are at risk of a proximity burn, bore wall contact burn, are outside the imaging field of view. It doesn't matter what field of view you're using. So the areas of risk are going to change with landmark. All of these bore wall contact burns, proximity burns, are going to occur, take a guess, look at the image, shoulder, upper arm, forearm, or elbow, forearm, wrist, possibly even the hand, okay? And so it depends on where you're landmarking as to what area of risk would be. Padding is required between the patient and the bore wall. Padding does not include sheets, pillowcases, blankets. We're talking padding, actual padding, okay? Here's a couple of examples from companies I'm familiar with. There are others that are out there, I'm sure. I'm just showing you companies I'm familiar with. Here you can see some the padding between the patient and the bore wall here. It's the actual patient. Here over here is an illustration courtesy of Dr. Frank Shellock, because that's actually Frank Shellock himself right there in the magnet. And this is a neat pad. It's from a company called Pearl Technology. It's called an angel pad. It's under the patient. You can see how as the patient goes in, it kind of folds up around them, kind of like a hot dog bun. It's kind of interesting and actually pretty cool, quite honestly. But nonetheless, my point is you need padding sufficient to provide about 1 centimeter or so or more of spacing. And here's the thing, this padding can't be uber compressed. If it's like really old and very compressed, you can still get a burn. So you've got to have this maximum space or padding. Please, please, please use proper padding between the patient and the side of the magnet. It's in all of your user manuals, telling you to do that. Now, here's the other thing, a couple other things about these bore wall contact burns. Number one, they don't show up right away. These burns occur in the deep tissue. So because they occur in the deep tissue, the patient doesn't feel it. And the patient not feeling it means they don't know it's occurring. And so it doesn't, they can walk out of the department and they feel just fine. But, several days later, even a week or so later, they can show up in the ER or their referring physician's office, and then they've got a full thickness burn like you see here. This does not occur at the time. The injury occurs at the time of the scan, but the patient doesn't feel it because it's within the deep tissue. So the lesion doesn't show up until later, days later. Okay. So giving the patient a squeeze ball is really kind of useless because they won't feel anything because they don't feel it because it's in the deep tissues. These burns can be life-altering. We're talking burns that are going to leave behind lasting results here. This next one I want to show you is one of the worst ones I've ever seen. This is a full thickness burn due to bore wall contact, and you're looking at the gentleman's ulna there. Okay. This gentleman will be lucky if he does not lose his arm. This is from an MRI scan done without padding between the patient and the bore wall. This occurred because of the inactions of the technologist. Okay? You have to provide padding between the patient and the bore wall. If the patient will not fit with adequate padding, then you need to have a policy and procedure from your MR medical director as to how to handle this. Scanning without appropriate padding is negligence. Okay? It doesn't occur every time you do it. This gentleman here on the right, he had had several scans before. He never had a burn before, but he had one this time. Okay? So, people say, well, we've never done it before. Okay, well, okay, fine, whatever. I'm telling you, you have to have proper separation, padding between the patient and the bore wall, period. The other actually fairly common type of burn has to do with skin-to-skin contact. Primary points of this, or places where you'd see this, is where you have a bare finger touching bare thigh, medial calves. This patient here was a type of body habitus where when she laid down, her feet flopped out to the side, and where her pudgy little calves were touching, she got skin-to-skin contact. And when you have small areas of skin-to-skin contact, that's where you can get these burns. So finger, thumb touching thigh, medial calves, medial thighs. You just need separation here. Now this, you can roll up a towel or something and separate. So you don't necessarily need the padding, but you just need some separation here. This is also why when, with general guidance, we recommend people will dress patients in MR appropriate attire. So for example, sorry, I'm dropping my earpiece here. So dress people in like a hospital gown and scrub pants. That's my favorite way to dress people. So that helps separate or prevent this skin-to-skin contact. Now let's take a look at another source of a thermal injury or burn, And this has to do with metallic items, conductive items in the bore of the RF scanner, particularly in the volume of the RF transmit coil. So when you take a look at electromagnetic radiation, you have three components to this electromagnetic wave. You have frequency, wavelength, and amplitude. Amplitude is strength. Frequency and wavelength will depend on the field strength. So you remember the Larmor equation, and with the Larmor equation, there's this relationship between field strength and resonant frequency. So at 1.5 Tesla, frequency is roughly, this is for hydrogen imaging, assuming hydrogen, then frequency is roughly 64 megahertz, 3 Tesla, roughly 128 megahertz, 7 Tesla, roughly 298 megahertz. So frequency changes as you change field strength. Well, wavelength, if you remember your X-ray physics, wavelength is inversely related to frequency. So as you increase the frequency, meaning increase field strength, you increase or rather the wavelength decreases. Okay? So here's an illustration I found online, kind of a neat one, that shows the way an antenna works. Optimal current induction in an antenna, which is an elongated conductor, is achieved when the length of the conductor matches a major harmonic of the RF wavelengths, specifically half wavelength. So what happens is if you put somebody in the magnet an elongated conductor of multiple centimeters in length, it can basically act as a very efficient antenna. And the heating is rapid and significant. As you can see here in this illustration, the temperature increases very rapidly over time. So here's some examples of such items, elongated or closed loop conductors. If you don't know their makeup, if they're not tested and labeled for use in MRI, they can result in a very significant heating. And in fact, they can heat so significantly they can cause a burn. Here's an example, courtesy of Dr. Frank Shellock, showing a burn from a halo device, such as you see here. And by the way, this device is this burn rather is superficial. So by the time they feel it, they've already been burned. So this again occurs very rapidly. Understand that not all metal is ferromagnetic, but all metal is conductive. And if you have electrically conductive material inside the bore of that magnet, your RF, your radio frequency, which includes an electromagnetic field, the electric field, can induce current in conductors. And this results in burns, okay? Carbon, for example, is an extremely conductive material. I had an email the other week from somebody who said at their facility they wanted them to start using these new gowns, and these gowns contained nickel fibers. Nickel is extremely conductive. It's electrically conductive, and it's conductive from a thermal standpoint as well. Bad stuff to be putting in to a radio frequency coil. So again, this is really important that these things be discussed or talked about, because this is the point of, or this is the origin of these injuries in MRI. Now let's take an elongated conductor and let's talk about the worst case scenarios here. So if you've got a wire that's insulated across its entire length, except for the tips, that's going to be kind of a worst case scenario, because if it's insulated, that's fine, but the tips aren't, then the energy is going to be focused at the tips of the leads, particularly if they're pointed. That's kind of problematic. The other thing that's interesting is if you're talking about a cylindrical bore magnet. Again, I told you that's what I'm really focusing on here. If the conductor is oriented in the superior or inferior direction, or head to foot direction, why does that matter? That's because the electric field of the electromagnetic wave is always oriented in the direction of the external magnetic field. If you remember, if your basic MRI physics, your B1 field is perpendicular to the main magnetic field. Well, the E field, the electric field of the electromagnetic wave, is perpendicular to that, which means it's oriented, in this case, along the head to foot direction, which means if you've got a wire, like an abandoned pacing wire, in the head to foot direction, it's in the optimal direction to be a good antenna, because the electric field's oriented in the same direction. Also radially positioned to the side of the bore. We talked about bore wall contact. Obviously, it's where the strongest electromagnetic field is for the RF. And then for length, and these are ballparks, and the reason they're ballpark is because the human body, being very conductive, actually alters the wavelength. So it depends on the patient's body size, as to what would be problematic. So ballpark, if you're at 1.5 Tesla, anything around 25 to 30 centimeters is kind of a high rent length for heating. Again, ballpark, 24, because it's okay, 32, I mean, it's okay. Just ballpark range. At 3 Tesla, you're going to be somewhere between 12.5 and 15 centimeters. This is the interesting issue with 7 Tesla. When you get up to 7 Tesla, right now we're only doing, as I understand it, worldwide, typically only doing head and extremity imaging. But at 7 Tesla, the critical length is going to be between 5 and 7 centimeters. That's pretty short. So that's going to be challenging if we get up the higher field. As you go to higher fields, shorter lengths become challenging. At 1.5 to 3 Tesla, I think it's reasonable. We did a podcast some time ago with a physicist from University of Wisconsin in Madison, and he was saying that when they get lengths of wires that are in the 11 centimeter or higher range, they kind of get concerned. And I think that's very wise. Would be a cause for a pause, as we say. And here's the other interesting thing. A lot of people have like 1.5 and a 3T and go, well, we don't know. Let's just put them on the 1.5, thinking the 1.5 Tesla would be less of a risk. And well, okay, not necessarily. Here is an example of a heating experiment done with, if I'm not mistaken, a pacing lead with no pulse generator attached. Essentially, it is the equivalent of an abandoned pacing wire. Okay. And as you can see, again, courtesy of Dr. Frank Shellock, as you can see, at 3 Tesla, this did not heat at all. No heating whatsoever. However, when the RF started at 1.5 Tesla, it heated tremendously. Okay. It heated very rapidly, and it heated tremendously. The other thing that's very important to notice is that at 1.5 Tesla, this was scanned at 1.4 watts per kilogram, which is below 2 watts per kilogram, that is below low SAR. And at 3 Tesla, this was scanned at 3 watts per kilogram. So limiting the SAR does not necessarily mean you're going to reduce the risk of a burn. And in this case, you can see that the lead heated more at 1.5. And the reason it did is because of the wavelength of the RF matching the length of the conductor at 1.5, but not at 3 Tesla. The other thing that's really important with implants or devices can be what particular transmit coil you're using. Now, this is, again, courtesy of Dr. Frank Shellock, but it shows a illustration of a deep brain stimulator. And in a lot of the deep brain stimulator conditions of use state that you have to have a transmit and receive head coil. And so if you're using a transmit and receive head coil, as you can see here, only the head is receiving the direct RF energy. If, however, you were to use a receive-only head coil, you're going to be transmitting with the integrated body coil, and then that's going to expose the device directly to RF radiation. Now, for this particular implant, it has to be, you had to use a transmit and receive head coil. The configuration of your coil, whether it's transmit and receive only, will actually vary with the vendor. You may or may not have one. They can look very similar, as you see here. They're very similar looking coils. It's extremely important that you know what coil you have and that you have these coils labeled so that someone doesn't pick an inappropriate coil. Here's an example of what can happen. This is a patient who had bilateral deep brain stimulators. The patient was a duck hunter and requested that one of the power supplies be implanted lower in, like down in his abdomen, so you could get the gun stock up and the shotgun stock up in his shoulder, right? And so, of course, the implanting surgeon said, sure, no problem. But of course, that resulted in a longer lead between the power supply and the brain. So the conditions of use for this particular device were 1.5 Tesla only, transmit receive head coil only, head SAR of 0.1 watts per kilogram. Unfortunately for this gentleman, he went to an imaging center that felt obliged to do a lumbar spine scan on him on a 1.0 Tesla, lower field strength, longer wavelength, longer lead, SAR obviously greater than 0.1 watts per kilogram because it was a lumbar spine. During the exam, the patient began exhibiting neurological symptoms, and when they were able to follow him up after stabilizing him, they found there was a large area lesion in the thalamus. Basically, this facility ablated his thalamus because the lead tip heated on this side. They didn't follow the conditions of use, and the patient wound up with a permanent thermal injury due to not following the conditions of use. Another way you can reduce the possibility of burns is not creating loops with coil cables, pad between the patient and the cable, any type of wire you want to insulate, something between that and the patient. You want to prevent conductive materials from contacting the patient. ECG electrodes that are not tested and labeled for use in MRI need to be removed. Here's a couple of examples of burns due to the use so what happens is the patient, well, there's several reasons this can happen, I guess. You can use these in MRI, but they're not MRI conditional. You haven't got the right ones. Or more likely what happens is the patient comes down from the floor. They've got these ECG leads all over them. Nobody thinks to roll and turn the patient to look at the patient to make sure these leads are cleared from them. I mean, they can put dozens of these all over the body. My father, before he passed away, was in the hospital, and he was going to go down and have an MRI, and I forget whether it was in the ER or whatever, but before they were going to take him down, I just knew they had him hooked up to EKG, and I looked up under his gown, and he had these things all over him. And so it's like, okay, let's get these off, you know, before you go down to MRI. And you've got to be careful because these things can be hidden. You absolutely have to inspect the patient very thoroughly before you put them in, particularly coming down from the floor. I've seen instances where wires and electrodes are like baked into sheets and stuff from the laundry in the hospital. So, you know, please make sure you inspect the patient visually before you put them in there for these things. Here's another situation that did not have to occur. This is from an academic children's hospital. But what happened was the anesthesiologist insisted on wrapping this young child in this so-called space blanket. They used them up in surgery because, you know, in surgery it's really cold. And so in surgery you lose heat, and they're worried about you losing heat. Well, in MRI, we're not worried about you losing heat because, quite honestly, we're going to apply radio frequency. We're going to warm you up. Okay. Nonetheless, this site, for whatever reason, allowed the child to be wrapped in this space blanket, which has a metallic backing on it. And immediately post MRI, you can see here, got a little lesion here. 5 days post-op, it's full thickness burn. They actually had to excise the wound. They couldn't close it. The child had a brain tumor. He died eventually from the brain tumor. But be that as it may, the child did not have to go through this because this should have never been allowed in MRI because I, if you don't know what it is and you didn't provide it, you really should not allow it into the room to touch the patient. You've also got to be absolutely certain that you're using only equipment that is designed and tested for use in MRI. One of the best ways to monitor the vitals of a patient undergoing an MRI, in my opinion, is pulse oximetry. You know, have leads, electrodes, stuff like that. And the other thing about pulse oximetry, it needs to be fiber optic, cannot be conductive. Conductive pulse oximeters are not to be used in MRI. You have to have fiber optic because you don't have electrical current in a fiber optic cable, which is glass. So here's the sensor, which really shouldn't have been used anyway because you can see it's got exposed wiring. But unfortunately on this 5-week-old female, they burned all the way through her tissues to the bone. It was non-viable and she lost her forearm, wrist, and hand because someone allowed a conductive pulse oximeter to be used. There are numerous cases of this. Here's an image, unfortunate image of a child who lost a finger due to the use of conductive pulse oximeter. For tattoos, tattoos are something you just have to monitor the patient. You just have to monitor the patient. If the patient feels any kind of irritation, then you can stop the exam. The ACR has said for years you can use a, what do they call it, cold compress to act as a heat sink. That's fine unless you got a tattoo like this, which, takes a big honking, cold compress. It's really not practical. Just monitor the patient. If the patient feels discomfort, then stop. The ACR and the FDA actually has reported some anecdotal, I've not seen it in published peer-reviewed articles yet, but anecdotal stories of tattoos that are smearing after exposure to MRI if the tattoo was placed less than like 48 hours. So for me, what I would be doing is I would be asking the patient, do you have any tattoos? Yes. How recent was the most recent one? If the most recent tattoo was less than 48 hours or so, with a day or two, then I'd probably go to the radiologist and ask, can we put this off until it kind of scabs over? Because you don't want to pay $1,000, for example. Or, I have no idea how much these cost, but I guarantee you that owl is not cheap. And you don't want to pay $1,000 for that to have it look like roadkill if it smudges on your skin. Now, if the exam is critical, yeah, you got to have it done. But I'm just saying if it's within a couple of days, then maybe the radiologist can consider, can we wait? If not, if we need to go ahead and scan the patient, or if I'm scanning a patient, any patient with tattoos, I don't, and I almost don't. I guess I want to know, do you have tattoos? But I'm not going to do anything about it. I'm going to give everybody the squeeze ball, and I'm going to tell them if you have any issues or feel anything during the scan, squeeze the ball, and we'll take a look at it. So I think that's really the best way to handle tattoos. As far as body piercings, body modifications, and piercings, remove all removable items. If you're unable to remove it, check to see if it's ferromagnetic. You can do that with a handheld test magnet. You can do it with ferromagnetic detection. If you have any questions at all and they can't take it out, depends on what you're scanning, clear it with your MRsafety officer or the MR radiologist. Make a case-by-case decision. There are a lot of sites that have policies and procedures that say, well, if you can't remove the jewelry, we're not going to scan you. I think that's a little much, okay? I want to know what it is, and if I can remove it, okay? It turns out that anything less than a couple of 3 centimeters is not going to heat. The FDA actually doesn't require anything less than 2 centimeters to be tested for heating if it's a passive device. When you're talking about heating, you really have to think about and consider the length. As we get to the end here, the last big thing I want to look at is metallic fibers in fabric. I can't stress this enough. You can't rely on clothing labeling. If the anatomy is going to be in the regions within the volume of the RF coil, you should dress the patient to skin. In other words, you should remove everything using only clothing provided by the MRI facility, preferably not nickel infused. Again, scrub pants, gown, and this should be without exception, everybody. Here's an example of an 11-year-old girl with just a long sleeve white t-shirt, gray sweat, gray undershirt. I mean, it's metallic fibers in clothing, unrecognized. This is second degree burns along her flank. Here's a significant burn, third-degree burn, due to metallic fibers in a stump shrinker, which is a item that's worn with prosthetic legs. Again, it has silver fibers in it, should be removed. Here's an instant with jogging pants. You can see the x-rays. You can see clearly metallic fibers. I don't understand why this went past the first scan, because this obviously has metallic um, artifact here, but nonetheless, whatever. Immediately following, you see this burn. A week later, you got this. The majority of patient injuries are in fact thermal events. Nearly 60% in this particular paper, looking at adverse events reported to the FDA between a 10-year period. And only probably about 10% of injuries are reported to the FDA. But the bottom line is the majority of these injuries are in fact thermal injuries, and they are preventable. There's no reason for these injuries to occur. So with that, I'm done. And Julian, I'm going to unshare here and go back to regular Zoom mode and see if we got any questions.
Wonderful. Thank you so much, Bill. That was another masterclass as usual from you. That's why we keep inviting you to be here with us. People love your presentations. I love your presentations. There was a quote there you said that not all metal is ferromagnetic, but all metal is conductive. And I think
Yeah,
this is really, really important. I think if people take any notes from today, this one is one of those things that you should write in a poster and have it in your MRI department because it's extremely important. Sometimes just because it's not ferromagnetic, it doesn't mean there's no risk involved. So
absolutely.
that's an amazing quote from your lecture.
Well, thanks. And it's not just metallic stuff. For example, carbon fiber. Carbon fiber is highly
Yeah,
conductive.
conductive. Yeah.
Okay. And so some of these orthopedic, fixation devices and stuff, can be carbon fiber and stuff. So it's really, really important,
Perfect. Bill,
for
thank
that.
you so much once again. So we'll start the fun part, I believe, which is the questions. I know Julian has been
Bring them
taking
on.
a lot of
Bring them
notes.
on.
We have loads of questions here on our chat. And Julian, do you want to
Okay.
start with any in specific, or you're just gonna do like a hand in the bucket and take one out?
Well, there are quite a few actually, so it's quite almost difficult to decide. I think we might need to keep Bill here for probably another 3 hours. Okay, let's try to
Yeah.
go in order. Mohammed.
I'm old. I don't have a job, so I'm good.
Well, Mohammed says, why is the head SAR limit fixed in both normal and first level control modes? So why is the head SAR limit fixed in both normal and first level control modes?
I do not know.
Yeah, that's a very genuine and honest question. Probably we should have someone of
I don't know.
yeah,
I don't know. Can't tell you, buddy. Can't tell you.
yeah. No,
It
well,
is.
I think that would be actually quite a nice question for the MR manufacturers as well.
I,
Yeah.
I really honestly don't know. Um, but the head's SAR is lower, if you notice,
Oh,
and the eyes are very sensitive. Okay, so that's one part of the issue. The other thing is that if you scan, and other vendors may do this as well, but I know it's more obvious on Siemens. On the Siemens system, the SAR estimate is different whether you're head first or feet first. And the reason is because it's an assumption of where the head is.
yeah.
Okay. And so because you've got fat, first off, SAR is an estimate. SAR is completely estimated. It's not measured. Okay. And part of the SAR estimate has to do with tissue conductivity. And in the body, muscle is more conductive than fat.
Yeah.
Most vendors in their SAR estimate assumes the patient is a bodybuilder. They take the worst case scenario because they don't know, right? It's also dependent on the circumference of the patient, which they don't know. So you take the weight of the patient, the height of the patient, and then they make these estimates, and they are grossly conservative. So again, to that question, the only thing I know is that the eyes, because they don't dissipate the heat, the eyes are more sensitive. You know, why is it the same? I don't know. But
Thank you, Bill.
there is a difference. That's about all I know about it.
Yeah.
So
No, absolutely. I think actually your explanation makes total sense. We get another one actually while you get a little bit more hydrated. I'll get actually quite a few from Subashri. I will try to ask one at least. So he is asking, in what real life situations can proximity burns occur? I think you gave quite a few examples if you want to
bore
repeat
wall
it.
contact, bore wall contact, bore wall contact. Patients touching the bore wall or very close to the bore. They don't have to be touching, but like extremely close. People go, well, how close? Close. Put padding between the patient and the bore wall, and then you don't have to worry about it. Okay.
Yeah, I can see
Bottom line.
there has been actually like a massive discussion about padding in the actual chat.
Yeah. And
And
another
we,
thing
Yeah.
is the sweat as well. The bore contact when the patient is sweaty is even worse. So
yes.
but
Does
any
it
kind of
matter? Nope.
contact
Nope.
should be
Don't
avoided.
matter. Don't matter. Avoid it. Put padding. Yeah.
I like this attitude, to be honest. Uh,
Pat him. Pat him, Dano. You remember Hawaii 5-0. I'm old. Hawaii 5-0. Book him,
um,
Dano. Pat him,
we
Dano.
we get another very interesting one actually from Patricia that has been following most of our webinars. She's asking, in the quest to fit more and more patients, are we in danger to go to first level and thus potentially introduce another increase in burns?
No. First, okay. Going to first level control mode is not a safety issue. I showed you that heating in that lead in low SAR, right? And at 3 watts per kilogram, the lead didn't heat at 3 Tesla. So going to first level control mode does not increase the risk of a burn to a patient. Patient comfort, yeah, okay, but does it increase the risk of a burn, especially if you've got no implant or device? If we're just talking about scanning in general, right? You're not going to melt somebody. No. They're going to get warm. Patient warming is not a safety issue. It's a comfort issue. Now, if you
Actually,
haven't,
I don't know, you know this for sure, but the GE scanners normally are set up pre-set up for scanning on first level.
well, yeah, I know, okay? I mean, because I grew up on a GE, okay? The GE scanners, I mean, I grew up on them. And actually, that's all I've ever really scanned on in real life, to be honest with you. I taught courses for Philips for a while, and people thought I actually scanned on the Philips. Yeah, well, I was pretty good at faking that off. But anyway, but the point is, in scanning, but you on the old style GEs, you had to pick normal first level when they like up front, and so you pick it up front, and you just pick normal because if you first level, because if you pick normal, you can't go to first level, right? You were this now GE's changed, as I understand their newest software, is that you can start in normal, and halfway through, if you need to go to first level, you can do it. You can't go back. Okay, but you can go. Now, and here's the thing. Even if you pick first level, okay, that just means you're going to be limited to 4 watts per kilogram. Does that mean I can't program a protocol to stay at 2 watts per kilogram or something like that? Oh, Lord, no. I can raise the TR for the number of slices. I can keep my SAR around 2 watts per kilogram. I can do whatever I want to, right? If I modify the parameters, then I can, get my SAR to whatever I want. Or, there was one vendor, Nevro, that asked me to do a white paper a couple of years ago. Can you do a lumbar spine at 0.4 watts per kilogram? I was like, sure, I can do it. I used to do it all the time. And then so I just go to the system and I sit down at the scanner with the tech and just modify the parameters, and I can get whatever SAR I want. So, yeah, even though, and a lot of the protocols, yes, maybe the library of protocols may in fact be at 4 watts per kilogram. I don't have to do that. I mean, I can reduce the SAR. I can shocker modify the protocol. And there's, sadly today, technologists aren't trained how to do that, because we didn't have all this automation. When I learned MRI in 1985, none of your business. We didn't have all this modification, all this automation. You had to actually do the protocol every time. And so, yes, you can do it. And I don't think any one system or another has got any kind of a empirical advantage over another one with SAR. But SAR has nothing to do with burns. I mean, I really want to get people to understand this. Get off the freaking SAR bandwagon. Whatever. You can't go above 4. It's a patient comfort issue. It's not a burn thing, okay? That's not your burn problem.
This clarification is quite important because I think it partially also tackle, I'm not sure if you want to add some comments about another question following up from Patricia, that she's also saying we now do have faster sequences. I think she also mentioned something about, she was assuming something about the application of AI. We know that we're going faster and faster. Does this mean higher energy levels and again might introduce new burns, perhaps?
No. Add between the bore wall. Avoid skin-to-skin contact, right? Keep metallic crap out of the magnet, okay? And you're going faster with AI because you're using lower averages, and you're not acquiring as much data, and it's the AI is differentiating between noise and signal. But it's not, you can burn somebody really quickly. I mean, you can burn somebody in a low SAR mode if you've got these focused RF issues. And that's why I'm saying, no, that has nothing to do with it. The burns occur bore wall contact, skin-to-skin contact, conductive materials in the magnet. They don't occur because you scan fast.
Can I ask you something, Bill? There's Jenna asked the question that it's a real life case for her. So she says, I have recently had a patient that had an MRI pelvis and received a pinch point burn on thighs and scrotum. Okay, this patient was wearing a gown and underpants. Padding was placed between thighs, but the scrotum large. I don't know what that means, but what would you suggest to prevent this from happening in the future? So basically, the patient was with a gown, hospital gown, and underpants. Maybe the underpants were the issue, and
No
maybe
underpants. No underpants. No underpants. I mean, I don't know, but underpants bother me. Okay, if you're doing a pelvis, I don't want anything on that pelvis that I didn't provide.
Absolutely.
And if I've got a legal case I'm actually working on right now, interestingly enough, in the U.S., and I was reading the document that was sent to me, and the patient had a sports bra on. Guess where a burn was? Underneath the breast. Okay, like undergarments have got to come off. It's a medical procedure. Take them off. if I go to have a procedure, my underpants are coming off. My wife's going to make me wear nice ones, but they're coming off. Uh, it's just, yeah, and I couldn't say I can't say whether that caused it, but if you got outside clothing on, I can't exclude that.
Yep, yeah. For another example is leggings, right? There's burns being reported with people wearing leggings. I don't
Leggings,
understand.
I don't know what the crap. Get it off. Take it
Sometimes,
off.
sometimes
Why
you
do you
can.
just take it off? Okay. You want to scrub pants, hospital gown, anti-slip stockings. Just get
That's
over it. Just
that's
do it. Yeah.
I'm gonna put two questions in one, and then Julian, I'll give you back. It's just this one seemed to come together kind of in the bundle. But there are people asking about ferromagnetic makeup, hairspray, and contact lenses. Contact lenses came recently as well on LinkedIn as a thing because some contact lenses now actually have a chip that allow you to control like phone or something like that. So people are asking that sometimes patients don't want to remove their contact lenses just because they're tinted or sometimes they're normal, but they don't want to remove it. So what's your take on ferromagnetic makeup, hairspray, and contact lenses?
Okay. If it's okay, so ferromagnetic, like, you're talking like magnetic eyelashes or something like that.
Yeah,
They're
yeah,
gonna
yeah.
they're gonna fly off if you don't take them off. Okay, if you put them, I got a video from Frank Shellock. They're gonna come off anyway. Okay, they're highly magnetic. You need to use ferromagnetic detection. A lot of people say, well, if you do everything right, you don't need ferromagnetic detection. I totally disagree with that. It's going to catch stuff you're not going to know. And if you use ferromagnetic detection, you're going to detect anything that's ferromagnetic the least bit, and it needs to come off. Uh, okay, now for like tattooed eyeliner, that kind of stuff. Dr. Frank Shellock did a paper, oh God, almost 20 years ago. It basically showed it really makes no difference. And I'm not really concerned about ferromagnet unless they come in looking like Tammy Faye Baker, for those of you that are old enough to remember that, or Boy George, for those of you. Anyway, unless they come in looking like that. And again, if I'm not doing their head, I really don't care. If they can take it off, take it off. Um, Hair extensions, you got to worry about that. It depends on what you're doing. If it's in part of a RF coil, how long is it? You have to take it in a case by case basis. And I think that's really what a lot of sites need to look at. You need to evaluate each one of these on a case by case basis. There could be problems, could not be. Magnetic fingernail stuff, the cat eye stuff. I, I only know this because my granddaughter's
Yeah,
13
there's
now, but
someone mentioning nail
yeah,
varnish as well.
yeah, nah, not a problem. I'm not aware of anything in the literature with that, anything like that. Okay. Um, there's artifacts, obviously, if you were doing a finger or a hand, but as far as from a patient safety standpoint, I'm not aware of anything, you know, any
So
burns from that. More of the stuff that's in the literature is all the clothing that people don't want to take off, So I'm not worried about all this little stuff uh, per se. And as far as uh, the jewelry, I'm not really worried about a lot of that. Most of that's very small as well, right? You know.
Julian, do you have any other questions there on your bank? You're muted. You're muted now.
Sorry, guys, my bad. Still that old mistake. No, I would just say thank you so much, Bill, for the explanation. I think that was great. And I was looking at a list of questions that I noted down, and I think with your explanation, essentially you already have majority of them. And I think you sort of like answer this one as well about the relationship between SAR and burns. But I think this is something that other radiographers, other MRtechs might ask as well. So Benjamin was asking, what outcome can we expect if patient weight is not correctly input at the start of the examination in terms of SAR and burns? would lower input of weight make more risk of burn because of incorrect SAR limitation? And that's, I think, one of the common concerns sometimes of radiographer, maybe rushing patient,
Yeah,
not having the.
SAR, yeah, here we go. SAR and the risk of burns are essentially unrelated.
Yeah,
Okay? The burns that I talked about and showed are unrelated. Now,
yeah. I
if you
think this
put
this
it
is this is supposed to be. I think this is a very good take-home message because it's something that really needed to be clarified. Very important.
right, you can't go above 4 watts per kilogram. 4 watts per kilogram is the limit. You are not going to burn somebody in the absence of an implanter device. Okay? In the absence of an implanter device, you are not going to burn somebody at 4 watts per kilogram unless you're touching the bore wall, you have skin-to-skin contact, you have metallic fibers in your clothing, and it doesn't matter what the crap SAR you're using. Okay, so all this worry about what SAR I'm going to use, if you're within the guidelines, I mean, you can't go above the limit. You're not going to melt somebody. That's not a burn. The burns are preventable because they're mostly positional.
Thank you, Bill. I think that was great. I think this was a great explanation, and I think it's always like a good reminder as well about all these basic concepts, but essential from a safety standpoint. I
Well,
don't
but
think,
everybody's been always been taught the SAR, keep the SAR down, keep the SAR down. It's fine. It's a comfort issue. It's not a safety issue. It's
yeah,
comfort.
yeah, absolutely, absolutely. This is essential. Sam, I think we already asked more than 10 questions, to be honest.
There's one here that I would like to ask is from Pedro, actually Pedro Cornejo. He's
Hmm.
saying about the RF range of 1 foot above and below the ISO center. Is this an experience concept or is there a document about this
Yeah,
that people can
very
actually
important
look
one. Yeah.
into and read? Is this from your experience or is this
Oh, the the
actually
the
literature?
the RF power
Yeah,
from ISO center up there.
center
Okay.
to up and down. Yeah.
Yeah. Okay. Every vendor is required to give you a RF power map for their integrated body coil. Okay. Now, you don't have to have a power map for your head coil, transmit receive head coil, or a
Okay.
transmit receive knee coil, because I can see the freaking coil, right? So I know, I can see the coil, I know where it is. But the integrated body coil, I can't see, right? So they're required to, and this is actually a very important point. I'm really so glad you brought this up. They are required to show you a power map. And I didn't show any, but they're required to show you a power map of the distribution of RF relative to this body coil. So you have this body coil that's, let's say, 60 centimeters for sake of argument. At 0 isocenter, you're going to have 100% of your RF power. And I showed that to you, I alluded to it a little bit on Manny's diagram. And as you go toward head or feet, it drops off kind of like a, curve, bell curve. But they have a map for you. That's only in isocenter. The problem is at the bore wall, as you saw on that illustration for Manning, it don't work that way at the bore wall. At the bore wall, it's high power all the way up and down that coil. The whole way. Doesn't matter whether you're isocenter or head or foot end, right? It's up and down the entire way. So that's why, again, that's why you want to avoid the bore wall contact. But if you, for example, had some item that you were worried about heating and it was more toward isocenter, which a lot of stuff is in the body, if you have that power map, you can say, okay, if I'm 25 centimeters, I'm making this totally up. If you look at that map and I'm 25 centimeters, say, inferior, superior to isocenter, it may be 10% of maximum RF power. that can give the radiologist a little bit of a help in maybe assessing the risk, if you will, of heating in terms of the amount of RF power. And I hope that answered the question, but that brought that to mind. Understanding the power maps that you see from the vendors are midline only because that's all they're required to give you. Midline. Sadly, that's all they're required to give you.
Perfect answer. Bill, thank you so much. We will try to wrap up now. There's a few more questions, but we would be here all night. We have another webinar. We have another webinar about safety coming next month on the 28th, if I'm not mistaken. So you guys can join us as well. Julien just shared the link tree. We have all our socials there, so you can follow us for more webinars like this. Of course, all of these questions can be answered as well on our MRIsafety forum, which is the biggest event that we normally do. Normally we have 1,000 people live. So we have other experts like Bill, we have Canal, we have Tobias. So we'll have a lot of people there. Before you go, I want to share with every single one of you that came today a discount code for our Everything MRI Academy. So you can choose any course that you want from our academy, and you'll have 15% discount. So this is the code. I'll put here the link as well.
There you go. And look at that. There's also like a sort of like statement of appreciation towards Bill.
Yes.
Faulkner 50,
Well, no.
15.
Well, I want to actually, I was just scrolling down through here and I saw a statement I'd really like to address. If you guys are okay before we go away.
Yeah, please.
It said, this person, Jill, said, we recently got told by our physicist that all stents are fine to scan and we don't need to ask about them anymore. Holy crap. What stents? Stents a broad term. Are you talking about coronary artery stents? If you're talking about coronary artery stents, I'm kind of good with that. But stent is a broad term. I don't like that. There are stents that are unsafe. There are ureteral stents that are unsafe or not tested. There are prostatic stents that are safe, not tested. Stent is a bad term. If you're gonna come up with a policy for coronary artery stents, you really should say that. I do not like the word stent. You know,
I really like this answer, and also the passion that Bill puts on this. I think makes it quite easy, to remember. Actually, if you like Bill's way of delivery, he's actually one of our lecturers in the foundational course, foundational MRI. He touched upon hardware, and he discussed plenty about K-space. I know you love K-space, Bill, right?
yeah. Yeah, once I get, I retire or something, I think I'm going to stand out on the street corner with a sign that says, I'll explain K-space for food or something like that,
Yeah, so just to let you know, Bill is actually part of this core team of amazing speakers. But yeah, Sam, do you have anything else you want to add?
No, it's just that you already mentioned the documentary that we're doing, and of course, a word of appreciation for Bill to be here once again. And he will join us once more on our MRIsafety forum at the end of the year in November. We will announce all of that. So for the next week and a half or something, just keep an eye for the next webinar. We're going to do a post about it. We're going to post the event. Just register. Again, we're going to cap it to 100 people. So if you get here late, you're not going to be able to watch it live. But of course, Julien is super kind and he edits all of this after the recording and he posts it on our YouTube channel. So you can catch it later as well. Bill, thank you so much once again. I just saw you share to your website as well.
Yeah, I put a link to my website there. Yeah.
𝐿𝐍𝐻𝑒𝐼.com. Please, guys, go there. Just click on the link and have what Bill has to offer, including courses. They are really good. And again, Bill, thank you so much. You've been a star.
My pleasure.
Such a nice.
I must
nice
say
code.
his lecture are always those that are most appreciated by our followers. So thank you so much, Bill, for the dedication. I know it takes time. We all know how much time it takes to put all the slides together, and the fact that you deliver this for free to the rest of the community is such like a very nice kind gesture from you. Thank you so much.
And
no problem. Actually, one last question here. How does matching wire length resonant affect, like how long does it take? It's instantaneous. So, anyway, I'm sorry. I can't keep answering the question. We'll get out of here. I gotta go.
Thank you. And thank you
Thank you
everyone
so
for
much.
coming. We truly appreciate every single one of you that keeps coming to our webinars and wants to learn as much as we do. That's why we do this every day. So thank you, Julian. Thank you once again for your
Thank you,
support.
Samuel. Thank you so much for leading
And
this. Much
see you
appreciated.
around, guys. Thank you very much. All the best.
Thank you all. Have a good
Bye
one.
bye.
Bye.